Welcome to the deep dive. When we picture the diagnostic landscape of pediatric gastroenterology, I think we tend to expect this mechanical precision, right? Like you look at an acute abdominal crisis in a kid, and you kind of hope for the clinical equivalent of, I don't know, a fractured femur.
Right, yeah. A clean break.
Exactly, a clean binary state that you can just see right there on a standard radiograph, just a jagged white line that lets a clinician point at it and declare the problem solved.
Yeah, but the reality of the ward is just profoundly different. I mean, the pediatric abdomen is essentially a black box when an acute crisis hits.
A black box, yeah. Because we're not just looking at a static pipe.
No, not at all. You are looking at a system that relies on this constant, highly regulated, one-way flow across literally miles of complex, actively secreting tissue. And when that flow experiences a sudden halt, the diagnostic clarity we all crave just, well, it vanishes.
Because it's not local anymore.
Right. You aren't just managing a local anatomical failure. You are immediately confronted with this systemic cascading emergency that compromises, multiple organ systems simultaneously.
Which is really the core mission for you and me today in this deep dive. We are unpacking the incredibly complex, often terrifying medical reality of pediatric intestinal obstruction.
Yeah.
And we are pulling directly from a really comprehensive set of clinical medical notes that cover, honestly, the entire spectrum of this pathology.
It's a huge topic.
It is. We're looking at everything from identifying the microscopic cellular origins of a blockage all the way to the intense time-critical emergency treatment protocols deployed in the hospital. The goal here is to shoot away the common misconceptions for you listening, like you might equate an obstruction with simple constipation, but we need to map out the rigorous life-or-death physiological reality.
That distinction is paramount. A pediatric intestinal obstruction, it drafts the kidneys, the lungs, and the entire cardiovascular system into this desperate fight to maintain homeostasis.
Wow, all of them.
All of them. If you are listening to this and visualizing a simple clogged pipe under your sink, you have to discard that image entirely. We really need to look at the gut as an active, dynamic ecosystem. When you introduce a blockade into that ecosystem, the resulting biological fallout can turn fatal with just alarming speed.
So to understand that fallout, I guess we first have to understand the normal baseline of the environment. The clinical notes define intestinal obstruction as the failure of onward passage of gastric and intestinal content.
Right.
But that phrase, intestinal content, it feels almost deceptive to me. Like it's too simple. We naturally think of ingested food. But the volume of material moving through the pediatric GI tract is mostly endogenous, isn't it? Like the body is constantly pumping its own fluids into the lumen.
Oh, absolutely. It is a massive secretory operation. I mean,
Yeah.
food is merely a fraction of the total volume. On a daily basis, the gut processes enormous quantities of gastric secretions, biliary output from the liver.
Bile.
Yeah, bile, plus intestinal juices and pancreatic enzymes. These are fluids actively secreted into the lumen just to facilitate digestion and absorption.
And that's not even counting the bacteria, right?
Exactly. You have a staggering population of gut flora, the microbiome, and all the metabolic byproducts of digestion itself. The notes specifically highlight the accumulation of gases, right? Nitrogen from protein breakdown, sulfites, and carbon dioxide.
So it's basically a highly reactive chemical soup.
That's a great way to put it. Yeah.
And it's actively fermenting. So if you suddenly cap that system, the secretions don't just stop. The bacteria don't stop metabolizing. The pressure has to begin to build exponentially behind that blockade.
Right. The environment shifts from this regulated, smooth flow to a pressurized, stagnant reservoir. And how the gut tissue actually responds to that pressure dictates the clinical classification of the obstruction.
Okay, so let's break those classifications down.
Sure. So the notes divide this pathology into two primary categories. You have mechanical, which is also referred to as dynamic obstruction, and you have adynamic or paralytic ileus.
Let's focus on mechanical first. This implies a physical roadblock, right? Like an actual structural impediment to the flow. But the notes break this down into three distinct subtypes, starting with simple intestinal obstruction. And I gotta say, simple feels like a dangerous misnomer in an acute pediatric setting.
Yeah, I agree. But it is strictly a morphological classification. A simple obstruction just means the blockage is entirely intraluminal.
Meaning inside the tube itself.
Exactly. The physical agent is blocking the hollow space of the gut, preventing the onward flow of the chyme secretions. Crucially, though, in a simple obstruction, the vascular supply to the intestinal wall remains completely intact.
Okay, so the blood is still flowing.
Right. The tissue is viable, It's perfused, and structurally it's sound.
The sources list some classic pediatric culprits here, right? Like ingestion of foreign bodies, severe fecal impaction, parasitic infestations like roundworms.
Oh, yes, roundworms.
Yeah, or the accumulation of bezoars. So the luminal flow is arrested, but the organ itself isn't suffocating.
The biological architecture is preserved, but the dynamic changes drastically when we move to the second subtype, which is strangulated obstruction. Here, the mechanical blockage is accompanied by a critical compromise to the mesenteric blood flow.
Okay, I want to trace the pathophysiology of that strangulation, because if we have a Luke of bowel that herniates, say, it pushes through a fascial defect in the abdominal wall, it becomes incarcerated.
Yeah, physically trapped.
Right. But the blood supply doesn't just instantly shut off like a light switch, does it? The notes describe a highly specific sequential vascular collapse.
It's all dictated by basic hemodynamics. The mesentery carries both the arterial supply and the venous drainage. Veins are low-pressure, thin-walled vessels. Arteries are high-pressure, muscular vessels.
So they react differently to being squeezed.
Exactly. When that loop of bowel is compressed at the neck of the hernia, the low-pressure venous return is the very first thing to be occluded.
Ah, okay. So the arterial blood is still slamming into the trapped tissue at full systemic blood pressure, but there is zero venous outflow.
You've got it. The tissue is acting as a one-way vascular trap.
The congestion must be immediate and just profound.
The localized hypervolemia is catastrophic. The capillary beds within the gut wall become massively engorged. The hydrostatic pressure inside the capillaries exceeds the oncotic pressure, and it literally forces fluid out into the interstitial space.
Which means swelling.
Severe edema. The intestinal wall swells rapidly, which, as you can imagine, only exacerbates the compression at the hernia neck.
It's a vicious cycle, because at a certain point, the internal tissue pressure has to exceed the systemic arterial pressure pushing the blood in.
And that is the exact inflection point of necrosis. Once that interstitial pressure surpasses the arterial perfusion pressure, the arterial inflow ceases entirely.
The blood stops.
Completely. The tissue is now completely ischemic. Hypoxia sets in at the cellular level. And without oxygen, ATP production halts, cell membranes fail, and the tissue undergoes gangrenous necrosis. The structural integrity of the gut wall just dissolves.
Leading to perforation. The physical barrier between the highly septic, pressurized interior of the gut and the sterile peritoneal cavity just fails.
Yes.
The contents spill out, triggering massive, often fatal peritonitis. It's a terrifying cascade that literally originates from a simple mechanical pinch.
It is. And the third mechanical subtype, closed-loop obstruction, carries a very similar risk of rapid catastrophe, but through a slightly different mechanical principle. This occurs when a segment of bowel is occluded at two distinct points.
Okay, 2 points. The notes highlight the ileocecal valve region as a prime location for this, right? The valve functions as a biological one-way door, letting flow into the colon but preventing reflux back into the terminal ileum.
Right, so if a mechanical blockage develops immediately downstream of that valve, you've created a sealed physiological compartment.
Because the bowel is still pumping fluid and gas into this segment.
Exactly. And the valve prevents backward decompression, while the blockage prevents forward clearance.
Oh, wow. So the luminal pressure would spike far faster than in a simple obstruction because there's absolutely nowhere for the volume to vent.
Yes. The wall tension increases according to Laplace's law. And even without an external hernia pinching the vessels, that sheer internal distension could stretch the gut wall until the intramural blood vessels are physically crushed.
Leading to ischemia purely from internal pressure.
Purely from the pressure. And the ischemic timeline in a closed-loop scenario is notoriously unpredictable and aggressive. So now, moving beyond the nature of the blockage, the clinician must also determine its anatomical origin. The notes differentiate between intrinsic and extrinsic mechanical causes.
Right. Intrinsic implies a failure in the embryological development or the structural integrity of the gut wall itself, like duodenal or ileal atresia.
Yes, where the lumen completely fails to recanalize during fetal development, basically leaving a blind-ending pouch, or a severe stenosis that abnormally narrows the passage.
Whereas extrinsic causes, conversely, leave the mucosal lining and the gut wall anatomically normal. The pathology lies out in the peritoneal cavity.
Right, outside the tube. The notes provide examples like profound intra-abdominal tuberculosis, or rapid-growing oncological masses like Burkitt's lymphoma or a nephroblastoma.
So a tumor expands within the limited confines of the abdominal cavity, generating mass effect. It eventually impinges upon the gastrointestinal tract, physically compressing that flexible tube until the lumen is totally obliterated.
And the clinical presentation might look identical to an intrinsic blockage from the outside, but the surgical intervention requires addressing a completely different primary pathology.
This brings us to a concept that kind of challenges the very definition of an obstruction. We've discussed mechanical roadblocks, tumors, hernias, atresias, but the second major category is adynamic obstruction or paralytic ileus.
Yes.
I really struggle to reconcile the terminology here. Like, if we define an obstruction as a blockage, how can a patient present with a profound, life-threatening obstruction when their intestinal lumen is completely clear?
It's a great question. It forces a shift in perspective from anatomical structure to neuromuscular function. You have to remember, the onward passage of chyme isn't passive. It requires the highly coordinated, rhythmic muscular contractions of peristalsis.
Right, the gut is actively squeezing the food down.
Exactly. And this motility is governed by the enteric nervous system and modulated by the central nervous system.
Yeah.
So in an adynamic obstruction, the anatomical pipe is fully patent. There is no physical roadblock anywhere. But the neuromuscular pump has completely failed.
The physical infrastructure is perfectly sound, but the electrical grid has suffered a catastrophic blackout. The motility simply ceases. But what systemic insults are powerful enough to paralyze the entire gastrointestinal tract?
The differential is incredibly broad because the enteric nervous system is just highly sensitive to systemic derangements. Severe pharmacological interference, particularly from opioid analgesics, can arrest motility.
Okay, drugs make sense.
Right. Profound systemic inflammation, such as overwhelming sepsis or septicemia, triggers a cytokine storm that inhibits normal neural signaling. Uremia from chronic kidney disease creates this toxic metabolic environment that suppresses the neuromuscular junction.
Wow, so the gut just shuts down in response to all this stress.
It does, but the notes specifically isolate metabolic derangement, most notably hypokalemia as a profound paralytic agent.
Hypokalemia, a severe deficit of potassium in the blood. I really want to drill down into the biophysics of why that specifically targets the gut. I mean, we experience mild potassium depletion and maybe suffer a localized muscle cramp in our leg. Why does hypokalemia cause the entire intestinal tract to undergo paralytic ileus?
It all comes down to resting membrane potentials.
Okay.
Potassium is the primary intracellular calcification responsible for maintaining the electrical resting state of the smooth muscle cells and enteric neurons.
Okay, so it's the battery charge.
Yes. When extracellular potassium levels plummet, the concentration gradient shifts. Potassium leaves the cells, leading to hyperpolarization of the cell membrane.
Hyperpolarization, meaning the electrical threshold required to trigger an action potential becomes much higher.
Exactly. The cells become refractory to normal stimuli. The pacemaker cells of the gut, the interstitial cells of Kayal, can no longer generate the slow waves necessary to initiate peristalsis.
So the neural signals are still firing.
They are firing, but the hyperpolarized muscle tissue simply cannot depolarize and contract. The entire organ system effectively goes dormant, not because of a physical barrier, but due to a microscopic ionic deficit.
It perfectly illustrates the fragility of the system. Just an invisible chemical imbalance paralyzes miles of tissue.
It really does. But to fully map out this diagnostic landscape, we have to establish the anatomical boundaries. The notes classify obstructions geographically, upper GI versus lower GI, and the demarcation line is incredibly precise.
The ampulla of Vater,
Yes.
located in the second part of the duodenum. For you listening, this is the anatomical watershed where the common bile duct and the main pancreatic duct empty their exocrine secretions right into the intestinal lumen.
Right. Any obstruction occurring proximal to or at the level of this ampulla, so involving the stomach, the duodenum, down to the proximal jejunum, is classified as an upper GI obstruction.
Proximal meaning before the blockage.
Exactly. Conversely, a blockage spanning from the distal jejunum and ileum all the way down to the rectum constitutes a lower GI obstruction. And this geographical distinction isn't merely academic, It fundamentally alters the pathophysiology, the clinical presentation, and the actual nature of the metabolic crisis the patient will endure.
Which transitions us directly into the cascading chain reaction. When that mechanical or adynamic halt actually occurs, how does the local environment react? The clinical text divides the gut into two entirely different ecosystems, right? The bowel distal to the obstruction and the bowel proximal to it.
Yes, the distal segment, so the part after the blockage, presents a deceptively calm picture. Below the point of occlusion, normal peristalsis just continues. The bowel actively clears out whatever residual gas and feces remain.
It just empties itself out.
All right. Once empty, without new volume entering, the distal bowel simply collapses and remains quiet. The true pathology is entirely concentrated proximal to the blockage.
Above the blockage,
Mm-hmm.
which is where we see the true definition of a physiological pressure cooker. The primary event is massive, relentless distension. You have the continuous influx of those gastric, pancreatic, and biliary secretions that we discussed earlier.
Endogenous fluids just piling up.
Yeah. But the notes also emphasize the profound contribution of trapped gases. Oxygen, carbon dioxide, and hydrogen ions begin to accumulate rapidly.
This is driven by the trapped microbiome. The bacteria in the gut are suddenly provided with a stagnant, nutrient-rich reservoir of undigested chyme.
An all-you-can-eat buffet for bacteria.
Literally. So they rapidly proliferate, and their metabolic fermentation produces massive volumes of gas. Because the lumen is sealed, this gas expands, driving the intraluminal pressure exponentially higher.
But the gut tissue isn't completely passive during this phase, is it? If it's a mechanical obstruction, the enteric nervous system senses the blockage and attempts to override it.
It does. It initiates violent hypoperistaltic contractions. The smooth muscle actually hypertrophies in an attempt to generate enough force to push the contents past the obstruction.
It's fighting back.
Violently.
Yep.
This hyperdynamic phase can persist for 5 to 7 days. The bowel is literally exhausting its own energy reserves, fighting an immovable object.
While that physical battle is occurring, the distension itself begins to sabotage the body's fluid dynamics. As the gut wall stretches like an overinflated balloon, the mucosal surface area undergoes a radical physical transformation.
Right, the microvilli, those microscopic structures responsible for fluid and nutrient absorption, become flattened and physically distorted by the sheer tension of the distended wall. The specialized transport proteins just fail.
So the gut fundamentally loses its ability to absorb fluid back into the systemic circulation. It becomes a one-way sink. The body continues to pump liters of secretory fluid into the lumen, but absolutely nothing is reabsorbed.
This phenomenon is known as third spacing. The patient is effectively hemorrhaging massive volumes of fluid and electrolytes. But rather than bleeding externally, they are losing it entirely into their own intestinal lumen.
Wow. Hemorrhaging into themselves?
Yes. They become profoundly hypovolemic and dehydrated, despite the fluid remaining technically inside their body.
As the hyperperistalsis eventually fails and the muscle succumbs to exhaustion, the presentation diverges radically based on that geographical line we established earlier, the ampulla of Otter. The level of the obstruction dictates a completely different metabolic disaster. Let's start with a high obstruction, an upper GI blockage.
Okay, so in a proximal obstruction, the reservoir capacity above the blockage is very small. The duodenum and stomach fill rapidly. The immediate, unavoidable reflex is severe, intractable vomiting.
The patient is rapidly expelling the accumulated fluid. But they aren't just losing volume, they are losing highly specific concentrated electrolytes. The stomach is actively secreting hydrochloric acid, right?
Right. When a pediatric patient with an upper obstruction vomits repeatedly, they're rapidly depleting their systemic reserves of hydrogen ions and chloride ions. They also lose significant amounts of sodium.
So if you strip the body of its primary acid source, the pH of the blood must shift dramatically. The clinical notes label this specific state as hypochloremic metabolic alkalosis. I want to break down exactly how the kidneys react to this because it's a brilliant, if destructive, compensatory failure.
It really is. So the systemic alkalosis, the abnormally high blood pH, is dangerous. The kidneys normally respond to alkalosis by excreting bicarbonate in the urine to bring the pH back down.
That's what they're supposed to do.
Right. But in this scenario, the patient is also profoundly hypovolemic from the fluid loss and hyponatremic from losing all that sodium in the vomit.
And the body will always prioritize volume over pH, right? Because if you have no blood pressure, you die immediately. If your pH is off, you die slightly later.
Precisely. The kidneys detect the severe drop in blood volume and go into overdrive to reabsorb sodium because water follows sodium. They desperately need to restore intravascular volume. But to reabsorb sodium from the urine, the kidney must secrete a positively charged ion in exchange.
Usually it would secrete potassium.
Usually, yes. but the patient is already depleted of potassium from vomiting.
So the kidneys are forced to secrete hydrogen ions acid into the urine just to hold on to the sodium and water.
Even though the blood is already dangerously alkaline.
That is insane. The kidneys are actively dumping the exact acid the blood desperately needs purely to maintain blood pressure.
That is paradoxical aciduria. The body's defense mechanisms are actively compounding the metabolic derangement. It is a lethal, self-sustaining feedback loop.
That is just wow. Okay, now contrast that with a distal obstruction, a lower GI blockage.
Right, so in a lower blockage, the reservoir capacity is enormous.
Mm.
Miles of small intestine must distend before the fluid backs up into the stomach.
So vomiting is a very late presentation. They aren't losing that localized pocket of hydrochloric acid early on, like in an upper obstruction.
Exactly. Instead, there are third-spacing massive volumes of alkaline intestinal and pancreatic secretions into the lower gut. They are losing bicarbonate into the stagnant luminal pool.
So they're losing base, not acid.
Right. And simultaneously, the profound dehydration leads to poor peripheral tissue perfusion. Hypoxic cells shift to anaerobic metabolism, which generates massive amounts of lactic acid.
And the failing kidneys probably can't excrete normal metabolic acids either.
They can't. The culmination of losing bicarbonate into the gut, generating lactic acid from ischemia, and failing to excrete uremic acids results in severe metabolic acidosis. The blood pH plummets.
It goes acidic instead of alkaline.
Yes. And a distal obstruction introduces another catastrophic variable, the failure of the mucosal barrier. As the intestinal wall distends to extreme dimensions, the tight junctions between the mucosal cells physically pull apart. The local ischemia compromises the immune defenses of the gut wall.
So those trapped proliferating bacteria we talked about, along with their endotoxins, they are no longer contained.
They translocate directly through the compromised gut wall into the peritoneal cavity and the portal venous system.
Oh, no.
The patient develops profound systemic sepsis. They are essentially being poisoned from the inside out by their own stagnant microbiome, which triggers high fevers, massive inflammatory cascades, and eventually septic shock.
So, armed with a deep understanding of this invisible physiological warfare, the fluid shifts, the metabolic acid-based disasters, the bacterial translocation, we step into the role of the clinician. How do you detect these internal cascades from the outside? The diagnostic detective work begins long before a physical exam. In some cases, it begins before birth.
It does. The prenatal history is a vital diagnostic window. Fetal physiology relies on a continuous dynamic cycle of amniotic fluid. A healthy fetus constantly swallows amniotic fluid, processes it through a patent gastrointestinal tract, absorbs the water, and excretes it via the kidneys back into the amniotic sac.
It's a closed-loop regulatory system maintaining the exact right volume of fluid around the baby.
Right. If the fetus has a congenital, high mechanical obstruction like duodenal atresia, that cycle is broken at the first step. The fetus swallows the fluid, but the physical blockage prevents it from passing into the absorptive surfaces of the distal intestine.
The baby is effectively drinking, but none of the fluid can be processed. It has to back up, and because the fetus is encased in the uterus, that backed up fluid just accumulates in the maternal amniotic sac.
The clinical presentation is maternal polyhydramnios, a massive abnormal accumulation of amniotic fluid visible on a prenatal ultrasound. If an obstetrician identifies severe polyhydramnios, the pediatric surgical team must be immediately alerted to the high probability of an upper GI obstruction awaiting them at delivery.
The notes brilliantly contrast this with oligohydramnios, which is too little amniotic fluid. If a fetus has, say, bilateral renal agenesis, so missing kidneys, they can swallow the fluid perfectly well, but they cannot excrete it as urine, so the fluid level drops. It is a perfect logical differentiation between a plumbing failure in the gut versus a plumbing failure in the kidneys, identified entirely through prenatal fluid dynamics.
Exactly. Now, once the child is delivered, the immediate postnatal presentation is highly dependent on the location of the obstruction. A neonate with an upper blockage will exhibit signs almost immediately. Because the proximal reservoir is so small, they can't even manage their own saliva.
You see excessive, continuous frothing at the mouth. They attempt to swallow, the fluid hits the blind pouch of the atresia, and it immediately regurgitates.
This creates an immediate critical risk of aspiration pneumonitis. The regurgitated fluid spills into the trachea, flooding the nascent lungs and causing acute respiratory failure.
But the most universal diagnostic milestone in the first 24 hours relies on tracking the lower end of the system, right? The passage of meconium.
The clinical notes rely on strict statistical timelines here. Meconium is the dark, viscous, tar-like substance that fills the fetal intestines. In a healthy neonate, 92 to 94% will pass meconium within the first 24 hours of life.
That's a huge majority.
By 48 hours, that number reaches 95 to 97%. So a failure to pass meconium within that critical 24-hour window is a blazing red flag. It strongly suggests a distal mechanical obstruction. The notes specify conditions like a meconium block where the substance itself is highly inspissated.
Inspissated meaning thickened or dried out.
Yes, it becomes desiccated, thick, and rubbery. It physically adheres to the mucosal walls. The neonatal peristalsis simply lacks the force to expel it, so it acts as an endogenous, simple mechanical obstruction.
Moving beyond the neonate, when assessing an older infant or child presenting with acute abdominal distress, the clinician has to interrogate the specific nature of the symptoms. An absolute most critical question regarding vomiting isn't the frequency, right? It's the color. Bilious versus non-bilious vomitus.
This loops directly back to our anatomical watershed line, the ampulla of Vater.
Right, so if the vomit is clear or white or contains undigested milk but totally lacks any green or yellow staining, it is definitively non-bilious.
This non-bilious presentation dictates that the obstruction must be located proximal to the common bile duct. The stomach contents hit the roadblock and reverse course before they ever have the opportunity to mix with the biliary secretions from the liver.
So the differential diagnosis immediately narrows to lesions like pyloric stenosis or a prepyloric web.
Exactly. But if the vomitus is bilious, if there is a distinct greenish hue, the diagnostic algorithm shifts entirely. Bilious vomiting indicates that the obstruction is located distal to the ampulla of Vater.
So the bile successfully enters the duodenum, encounters the downstream occlusion, and the retrograde peristalsis forces the bile-stained chyme back up through the stomach and out the esophagus.
Yes, it is an immediate, critical indicator of an obstruction involving the midgut or hindgut.
The physical presentation of the abdomen itself provides the next layer of clues, the topography of the distension.
Right. In a proximal upper GI obstruction, the massive generalized distension hasn't occurred yet. If distension is present, it's highly localized, you might see a periumbilical fullness. But frequently, because the patient is relentlessly vomiting every drop of fluid they ingest, the abdomen is actually scaphoid.
Scaphoid, meaning sunken, concave, because the stomach and intestines are completely empty and collapsed.
Contrast that with a distal lower GI obstruction. The vomiting is delayed by days. The entirety of the small intestine and proximal colon acts as a reservoir for the third space fluids and fermented gases. The patient presents with profound, generalized, tense distension, often most prominent in the suprapubic region.
The history must also cover the nature of the stool, assuming any is passing at all, and the notes single out a highly specific visceral presentation, current jelly stool.
Ugh. Yes, it is the pathognomonic sign of intussusception.
We briefly touched on this. A segment of the intestine telescopes into the adjacent distal segment. But how does that physical folding create this specific type of hemorrhagic stool?
Well, the intussusception is usually driven by a lead point, perhaps an enlarged lymph node in the gut wall. The hyperactive peristalsis grips this lead point and physically drags the proximal bowel inside the lumen of the distal bowel.
Like a sock turning inside out.
Right. And as the inner layer is pulled deeper, it drags its mesentery and its vital blood supply along with it. The vessels are compressed tightly between the overlapping layers of the intestinal wall. Venous drainage halts. Arterial inflow continues until the pressure causes ischemia.
We've seen this pattern.
Exactly. The invaginated mucosal layer rapidly becomes ischemic and undergoes necrosis. It begins to slough off, bleeding heavily into the lumen. The inflamed goblet cells produce massive amounts of mucus.
And so that combination.
Yes, this combination of necrotic tissue, fresh blood, and thick mucus is expelled rectally. It visually mimics dark red currant jelly. It is a terrifying signal of active, severe intestinal strangulation and tissue death.
The history also warns clinicians not to be fooled by the presence of diarrhea, which seems so counterintuitive. A mechanical obstruction naturally implies absolute constipation. How can a blocked pipe produce liquid output?
A partial or incomplete obstruction can create a paradoxical presentation. If a stricture or a mural tumor narrows the lumen significantly but doesn't obliterate it completely, solid matter will impact and halt. But highly liquefied hypersecretory fluid can still forcefully squeeze past the narrow aperture under high peristaltic pressure.
So the patient is clinically obstructed, the bowel is distending and suffering, but they are passing liquid stool.
which can easily lead a less vigilant clinician to diagnose simple gastroenteritis instead of a surgical emergency. Inflammatory processes adjacent to the bowel, like severe pelvic inflammatory disease, can also aggressively irritate the serosal surface of the gut, triggering violent hypermotility that forcefully evacuates liquid stool despite a distal partial occlusion.
So the history provides the roadmap, but the physical examination is where the clinician must confront the immediate systemic toll of the pathology. The bedside assessment isn't just about feeling the abdomen, it is an immediate triage of the patient's physiological stability.
Absolutely.
These pediatric patients arrive profoundly volume depleted. The third spacing and vomiting have robbed them of their intravascular volume. The first target is the sensorium.
The brain is highly sensitive to cerebral perfusion pressure. As hypovolemia sets in, cardiac output drops and cerebral blood flow is compromised. Furthermore, the profound electrolyte shifts, particularly hyponatremia, disrupt neuronal action potentials.
So how does the patient look?
The patient will present with altered sensorium. An infant might be hyper-irritable initially, transitioning rapidly into profound lethargy, weakness, and unresponsiveness as shock deepens. The clinician must immediately assess the hemodynamics to determine how close the patient is to total cardiovascular collapse.
You start with the peripheral indicators. A normal bounding pulse indicates adequate stroke volume. But in hypovolemic shock, the circulating volume is drastically reduced. The body compensates via massive sympathetic nervous system activation, right?
Yes. Catecholamines adrenaline are dumped into the bloodstream to trigger systemic vasoconstriction. The body is desperately clamping down on the peripheral blood vessels to shunt whatever blood is left to the brain and the heart.
And this intense vasoconstriction alters the character of the pulse.
It becomes extremely rapid tachycardia as the heart attempts to maintain output, but the volume is so low that the pulse feels feeble and thready. It may be entirely unpalpable at the radial artery.
This peripheral clamping is directly visualized through the capillary refill test. You blanch the nail bed or the skin over the sternum, physically pushing the blood out of the capillary bed. In a well-perfused patient, the capillary pressure rushes the blood back in less than 2 seconds.
But if the sympathetic nervous system has maximally clamped those precapillary sphincters to save the core organs, the refill is sluggish. A capillary refill time extending beyond 2 seconds is a glaring indicator of significant peripheral hypoperfusion and impending decompensated shock.
And when that compensatory vasoconstriction eventually fails, you see profound hypotension. The blood pressure collapses.
Yes.
But the notes also direct the clinician to look closely at the chest, specifically assessing the respiratory rate. This isn't a primary pulmonary disease. The rapid breathing is a secondary compensatory response.
It is the respiratory compensation for the severe metabolic acidosis we discussed in distal obstructions. The lactic acid and uremic acids have plummeted the blood pH. The body's primary buffers are overwhelmed.
So the peripheral chemoreceptors in the carotid bodies and aortic arch detect the lethal acidity and signal the respiratory center in the brainstem.
Exactly. And the fastest way to pull acid out of the blood is to alter the carbon dioxide concentration. According to the Bohr effect and the bicarbonate buffer system, dissolved CO2 acts as an acid.
By triggering hyperventilation rapid, deep breaths known as Kussmaul respirations, the lungs blow off massive amounts of CO2 into the atmosphere.
The patient is physically hyperventilating to forcibly drag the blood pH back toward a neutral state. A fast respiratory rate in this context is literally the sound of the body frantically attempting to stave off a metabolic coma.
Once the systemic stability is assessed, the focus narrows to the abdomen. But you don't touch it immediately. The clinical instruction is specific. Inspection precedes palpation. You watch the surface of the skin.
In a pediatric patient, particularly one who is emaciated or severely dehydrated, the abdominal wall is thin. If the underlying bowel is in the early hyperdynamic phase of fighting a mechanical obstruction, you will actually see visible peristaltic waves rippling across the surface of the abdomen.
Wow, visual proof of the smooth muscle violently contracting, trying to ram the chyme past the occlusion.
Right. It confirms that the enteric nervous system is active and fighting. But the absence of those waves, coupled with an absence of bowel sounds upon auscultation, paints a much more sinister picture.
A silent, distended abdomen indicates that the fight is over.
It implies the hyperperistaltic phase has failed. The smooth muscle is entirely exhausted and the bowel is flaccid. Or it confirms a primary paralytic ileus. Or worst of all, it suggests that bacterial translocation has caused widespread peritonitis and the extreme inflammation has paralyzed the entire visceral cavity.
A noisy abdomen is dangerous. A completely silent, tense abdomen is terrifying.
Exactly. When palpation finally begins, the clinician's hands are searching for highly specific morphological clues. The notes describe identifying distinct masses that correlate directly with distinct pathologies.
Okay, so if the clinician feels a firm, discrete, olive-shaped mass deep in the right upper quadrant or epigastrium.
That is the pathognomonic physical finding for hypertrophic pyloric stenosis. The circular smooth muscle of the pyloric sphincter, the valve controlling exit from the stomach, has hypertrophied massively. It thickens and enlarges until it physically feels like a hard aller beneath the abdominal wall, completely obliterating the luminal exit.
And if the mass is described as tubular or sausage-shaped, often located in the right upper quadrant or stretching across the upper abdomen.
That correlates with the intussusception. The clinician is physically feeling the telescoped layers of bowel, swollen with edema and trapped blood, acting as a rigid, sausage-like tumor within the abdomen.
Palpation might also reveal a mass in the right iliac fossa, suggesting a walled-off appendiceal abscess causing local paralytic ileus, or an irreducible mass in the groin, confirming an incarcerated inguinal hernia.
And if a rock-hard mass is palpated centrally in the suprapubic region, it is overwhelmingly likely to be severe fecal impaction, a massive accumulation of desiccated stool acting as a concrete roadblock in the distal colon or rectum.
Which mandates the final, non-negotiable step of the physical exam, the digital rectal examination.
The DRE cannot be bypassed. In a neonate, it instantly rules in or rules out an imperforate anus, a complete failure of the anal opening to form. In older children, the clinician can directly palpate the lower limits of a pelvic mass, assess for polyposis coli, physically feel the extent of a fecal impaction, or identify the presence of that current jelly mucus in the rectal vault.
So the physical exam gives the clinical team a highly educated, tactile hypothesis. But to convert that hypothesis into a definitive surgical plan, they must map the internal landscape using investigations, lab work, and radiology. But the clinical notes issue a really severe warning regarding the laboratory results, specifically concerning the complete blood count. There is a massive potential for misinterpretation here.
It centers on the hematocrit value. The hematocrit represents the volume percentage of red blood cells in the total circulating blood volume.
Right, so a clinician reviews the lab panel and sees an exceptionally high hematocrit reading. The immediate instinctual assumption might be that the patient has a robust red blood cell count, excellent oxygen carrying capacity, and is not anemic.
Making that assumption in the context of an intestinal obstruction ignores the profound fluid shifts occurring in the patient. The high hematocrit is a dangerous illusion. It is a false high caused by severe hemoconcentration.
The mechanism here relies on Starling forces. The patient is continuously vomiting and third-spacing liters of fluid into the gut lumen. That fluid is drawn directly from the intravascular plasma volume.
The water leaves the blood vessels, but the large cellular components, the red blood cells, remain trapped within the shrinking intravascular space.
So the total volume of blood is rapidly contracting. So the ratio of red blood cells to plasma skyrockets. The blood essentially turns to sludge.
Exactly. The high hematocrit doesn't indicate health. It is a critical glaring marker of severe life-threatening dehydration and intravascular volume depletion. The lab work also quantifies the metabolic disasters we discussed, verifying the exact levels of hypokalemia, the hyponatremia, and the specific acid-base derangement via serum electrolytes and arterial blood gases.
But the structural map of the pathology must be generated radiologically. The primary immediate imaging modality is the plain abdominal X-ray, specifically acquired in the erect position if the patient's stability allows. And the most famous, instantly recognizable radiological hallmark in pediatric surgery is the double bubble sign.
It is the definitive diagnostic image for a proximal obstruction, particularly duodenal atresia. When a patient stands erect, gas rises to the highest possible anatomical point and fluid settles below it, creating a distinct, straight horizontal line on the radiograph.
In a normal, healthy patient, you only see one bubble of gas located in the left upper quadrant.
That is the normal accumulation of swallowed air resting in the fundus of the stomach. But in duodenal atresia, the lumen is completely obliterated just past the pylorus. The gas and fluid cannot progress.
So the stomach distends enormously, creating the first massive bubble. And the small proximal segment of the duodenum, caught between the pyloric sphincter and the dead end atresia, also dilates massively, creating a second distinct bubble in the right upper quadrant.
The radiograph displays two large, distinct pockets of trapped gas with flat air fluid levels beneath them, the double bubble. It immediately confirms the anatomy of the blockage.
If the obstruction is located further downstream, in the distal small bowel or colon, the radiographic presentation changes to multiple air fluid levels.
Because the entire length of the bowel is paralyzed and massively distended, the gas and liquid contents separate in every affected loop. On the erect X-ray, the clinician sees a cascading series of short, straight horizontal lines across the entire abdomen. Multiple loops of bowel acting like a series of half-filled water glasses stacked upon one another.
While plain films visualize the gas patterns, contrast studies are required to map the exact internal architecture of the lumen.
Right, a radio-opaque contrast agent, typically barium, is introduced. For a suspected upper GI defect like malrotation, where the embryonic gut failed to rotate properly, leaving the intestines prone to twisting around their own vascular pedicle, a barium meal or follow-through is performed.
The contrast is ingested, and fluoroscopy tracks its rapid descent, pinpointing the exact location where the flow twists into a corkscrew pattern or halts entirely.
For lower GI suspicions, a barium enema is utilized. The contrast is introduced retrogradely via the rectum. This maps out the colon, identifying transition zones in Hirschsprung's disease, outlining meconium plugs, or visualizing the classic coiled spring appearance of an intussusception.
And crucially, the barium enema can actually be therapeutic, right?
Yes, the hydrostatic pressure of the barium column, strictly monitored under fluoroscopy, can sometimes generate enough reverse force to physically push the telescope segment of the intussusception back out, reducing the obstruction without the need for an incision.
That is incredible. Finally, the abdominal ultrasound has revolutionized specific diagnoses. It is the absolute gold standard for hypertrophic pyloric stenosis. The sonographer can visualize the exact dimensions of the hypertrophied pyloric muscle, measuring the wall thickness and channel length with millimeter precision, avoiding ionizing radiation entirely.
The diagnostic picture is now complete. The lab work has quantified the metabolic and hemodynamic collapse. The radiology has pinpointed the anatomical roadblock.
The pediatric patient is critical. This brings us to the final, high-stakes phase, the rescue mission, the treatment and management protocols.
The immediate instinct of a layperson, and sometimes a junior surgeon, might be to rush the patient straight to the operating theater to surgically resect the blockage.
Let's just fix the pipe.
Exactly. But the clinical notes strictly prohibit this. You cannot induce general anesthesia and subject a patient to a major laparotomy when they are in hypovolemic shock with a deranged blood pH and plummeting potassium levels.
The anesthetic agents and the surgical trauma will instantly precipitate cardiac arrest.
Right. The physiological foundation must be stabilized first. Priority 1 is aggressive fluid resuscitation. The goal is to rapidly restore intravascular volume and correct the electrolyte derangements. The notes specify the use of isotonic plasma expanders.
Fluids that will remain within the vascular space rather than instantly third spacing into the tissues. And the fluid of choice highlighted in the protocols is Ringer's lactate. Why is this specific formulation so superior to standard normal saline in this crisis?
Normal saline is simply sodium and chloride in water. Pushing massive volumes of it can actually induce a hyperchloremic acidosis, worsening the patient's state. Ringer's lactate is a balanced physiological crystalloid. It contains sodium, chloride, potassium, and calcium in concentrations that closely mimic human plasma.
It addresses the hypokalemia and hyponatremia simultaneously. But the critical component is the lactate, isn't it?
Precisely. In a state of metabolic acidosis, which we see heavily in distal obstructions and septic shock, the body needs a buffer. When Ringer's lactate is infused, the liver metabolizes the lactate molecules into bicarbonate.
Oh, so it acts as an endogenous source of bicarbonate, actively neutralizing the lactic and uremic acids in the bloodstream, gently pulling the blood pH back toward a safe, neutral baseline.
It's exactly. Depending on the child's specific metabolic panel and age, dextrosaline might also be deployed to provide an immediate glucose substrate for cellular energy. But Ringer's lactate remains the foundational resuscitative fluid.
Concurrent with the IV fluid resuscitation, the clinician must address the internal pressure cooker. Step 2 is physical decompression via a nasogastric or NG tube.
Yes.
I try to visualize the reality of this. Taking a rigid plastic tube and forcefully passing it down the nasal cavity, past the pharynx, and into the stomach of an already agonizingly sick, terrified pediatric patient. It seems barbaric, but the physiology dictates that it is an absolute, non-negotiable lifesaver.
It is. The stomach and proximal intestines are stretched to the point of ischemia by liters of trapped fluid and expanding gas. The NG tube acts as an immediate mechanical pressure release valve. By continuously aspirating the gastric contents, it achieves three vital goals.
First, it empties the gastric reservoir, functionally eliminating the risk of the patient vomiting and aspirating toxic fluid into their lungs.
Second, by removing the volume and reducing the stretch on the gastric wall, it decreases the stimulation for further reflex hypersecretion. It breaks the cycle of continuous fluid dumping into the gut.
And third, it transforms the fluid management from guesswork into precise mathematics. The notes stress the strict monitoring of input and output.
The clinical team must calculate the exact volume of fluid the patient is losing to determine the exact volume of 5E resuscitation required. The output chart meticulously records every milliliter of aspirate pulled from the NG tube alongside the urinary output measured via a catheter.
The input is the tightly controlled 5E fluid rate.
It is a continuous dynamic balance sheet designed to pull a patient out of hypovolemic shock without pushing them into fluid overload.
While the fluids are balanced and the gut decompressed, pharmacology is deployed to manage the pain and the invisible systemic threats. The notes mandate an analgesic agent to manage the severe colicky pain generated by the hyperperistalsis and distension.
Pentazocine is specified, dosed meticulously at 1 milligram per kilogram per day. Controlling the pain reduces the massive sympathetic nervous system drive, which in turn helps lower the extreme tachycardia and systemic stress.
But the more critical pharmacological intervention is the deployment of targeted antibiotics. We detailed the terrifying reality of bacterial translocation earlier, the gut flora escaping through the ischemic mucosal barrier into the bloodstream.
The patient is either actively septic or at extreme risk of imminent sepsis. You cannot wait for blood cultures to grow and identify the specific organism.
It takes too long.
Way too long. The clinical protocol demands immediate broad-spectrum triple therapy antibiotic coverage to carpet bomb every potential class of invading bacteria.
The notes list 3 specific weapons. First, metronidazole.
Metronidazole is specifically deployed to hunt down anaerobic bacteria organisms like Bacteroides fragilis that thrive in the oxygen-depleted necrotic environment of the obstructed gut. It penetrates the bacterial cell and disrupts their DNA synthesis.
Next, a third-generation cephalosporin.
This class provides robust coverage against gram-negative enteric bacilli, such as E. coli and Klebsiella, which represent the vast majority of the normal, now translocated, gut flora.
Finally, penicillins are added to the regimen to ensure coverage against gram-positive organisms like Enterococcus.
This triple shield must reach therapeutic levels in the bloodstream to neutralize the sepsis before the surgeon ever makes an incision.
Once the resuscitation is underway, the hemodynamics stabilize, the gut decompress, the antibiotics circulating, the surgical team faces the ultimate decision, the 48-hour ultimatum.
The clinical notes dictate that surgery is not always the immediate next step. In cases where the presentation is ambiguous or a partial adynamic state is suspected, the protocol advises conservative management.
You maintain the NG suction, you continue the IV fluids, and you watch closely.
The bowel is essentially placed on complete physiological rest. Often, as the edema subsides and the spasm relaxes, a partial or functional obstruction will spontaneously resolve within 24 to 48 hours.
But that 48-hour window is a hard physiological limit.
If the clinical signs of obstruction, the distension, the high NG output, the absent bowel sounds, persist beyond 48 hours despite optimal conservative management, the risk of ischemic necrosis and perforation becomes too great.
Or if at any point during the initial assessment, the clinician confirms definitive signs of a strangulated mechanical obstruction, like the current jelly stole of an intussusception or the rigid olive of a pyloric stenosis, there is absolutely no waiting period.
Those findings trigger an immediate emergency exploratory laparotomy. The abdominal cavity is open. The surgeon must physically locate the blockage, untwist the volvulus, resect the necrotic, gangrenous segments of bowel, and bypass the atresia.
The notes also emphasize that if the diagnosis is a purely adynamic obstruction, surgery is functionally useless. If the underlying cause is hypokalemia paralyzing the enteric nervous system, the treatment is entirely medical.
You aggressively replete the potassium via carefully monitored IV infusion. As the extracellular potassium levels rise back to normal, the resting membrane potentials of the smooth muscle cells stabilize. The electrical grid comes back online, peristalsis resumes, and the obstruction simply ceases to exist.
It's an incredible realization. You correct a microscopic ionic deficit in the bloodstream, and an entire paralyzed organ system boots back up and resumes its baseline function.
It perfectly encapsulates the entire diagnostic journey mapped out in these clinical notes.
Synthesizing this deep dive, the overriding theme is that the pediatric gastrointestinal system is infinitely more complex than a simple conduit for food. It is a highly sensitive, dynamically balanced ecosystem. When a mechanical blockage or an adynamic failure stalls that flow, the resulting cascade is violent and systemic. We've traced the pathology from the localized physical tearing of ischemic tissue to the profound alteration of the blood's acid-base chemistry to the deceptive, terrifying quiet of an exhausted septic abdomen.
The clinical reality demands that we view the human body through the lens of absolute interconnectedness. An intestinal obstruction is a systemic alarm bell. The moment luminal flow halts, the kidneys are forced into a desperate paradoxical battle to maintain volume at the expense of pH. The lungs are drafted to hyperventilate and buffer the metabolic acid. The cardiovascular system is stressed to the brink of hypovolemic shock. Treating this pathology isn't just about cutting out a roadblock. It requires a clinician to meticulously manage a collapsing physiological ecosystem until the structural integrity can be restored.
It fundamentally rewrites our initial analogy. The diagnostic landscape here is a million miles away from the simple precision of a broken bone. It requires an understanding of fluid dynamics, cellular resting potentials, and embryological development. It leaves you with a lingering, profound thought about your own baseline health. The next time you experience something as mundane as your stomach rumbling, consider the precise, microscopic symphony of electrical signals, ionic gradients, and muscular contractions required just to move a single drop of fluid from one end of that tract to the other. If a subtle shift in your blood's potassium concentration can trigger a system-wide paralytic failure, how much of our everyday presumed health is actually riding on a microscopic invisible tightrope? Thank you for joining us on this deep dive, and keep exploring the fascinating, terrifying wonders of the human body.